Okay, so I'm a nuclear medicine specialist, working at Acibadem City Clinic, Sofia. Um, and I will not focus exactly on nuclear medicine imaging, but on nuclear imaging, imaging in general, because the problems and the solutions are the same. Reading or reporting or interpreting a scan for a cancer patient can be done on very different levels. In almost half of the cases, you will have report including identification of abnormal findings and their specification, either malignant or benign or equivocal or I don't know, and some kind of conclusion. Here we have a patient with massive mediastinal and hilar lymphadenomegaly, which as a basic reading can result in only one thing. There's a cancer patient, large hot lymph nodes. These are lymph node metastases. Well, somebody can ask himself, okay, this is a breast cancer patient. Do we expect mediastinal lymph node metastasis in such an extent? We don't. So probably we should include some differential diagnosis in the report. Something like it could be another primary cancer, lymphoma, granulomatosis, something. We should recommend biopsy. Actually, this case is very easy if you go through the entire medical history of the patient. It's detailed history, detailed histology, and the clinical question that is actually answered. When you have the idea of the primary tumor, you already have pre-mapping in your head what to expect and what not to be expected. So if we recheck again this case, this is breast cancer, but this is lobular cancer with KI 67.8%, very low risk profile, negative axilla. So only from here I can tell you these are not metastases from lobular cancer. If we go for the recognition of the pattern, my colleagues here will directly say this is sarcoidosis. You don't need anything but just to see the entire picture. So you need medical history and you just have to take a glance at your picture and you have your diagnosis. So what is a pattern recognition in nuclear cancer imaging and in imaging at all? This is a very sophisticated definition that cost me about half an hour to compile, which actually means specific type of tumors have specific behavior and specific appearance. If we know these specificities, we can resolve the case in seconds. So here as a pattern recognition, the first picture shows activated brown fat, the second picture shows sarcoidosis, and the third picture is obviously a lymphoma. So where's the place of nuclear medicine in imaging in gynecological cancer, if we want to focus on gynecological cancer? You can go through the NCCN guidelines and see it was not recommended probably 10 years ago. Now it's everywhere. In certain occasions it's underrated, in certain occasions it's severely overrated. I don't see a rationale to stage a patient with high-grade serous cancer with PET-CT. I mean, I see zero idea in that. It should be done surgically. When we talk about gynecological cancers and pattern recognition, we have to focus and know the types of metastatic spread. We know local invasion, lymph node, and distant metastasis, but that's not all. Local spread in the peritoneal cavity is very typical for gynecological cancers. The lymphatic spread could be either lymphovascular or lymphonodular at the end stage. Hematogenic spread is okay. Don't forget perineural spread. It's very typical for spinocellular cancers. Other types of spread are not an issue or at least a major issue in gynecological cancer. So the peritoneal spread could be, on imaging, could be two different types. Diffuse type, either thin layer carcinomatosis or massive carcinomatosis like on mental cake, for example. or focal type ranging from small nodules to large masses. This is a typical case of diffuse type peritoneal carcinomatosis readily seen on FDG PET. If you want to assess that, do FDG PET. Don't do CT scan or MRI. They will underreport the peritoneal carcinomatosis. This is how it looks on FDG. This is how it looks on CT scan. When we have ascites, it's easy. When we don't have ascites, it's not that easy, so you should rely on metabolic imaging only. Lymphatic spread, as I said, could be lymphovascular, or which is not interesting in gynecological cancers, or lymphonodular, which is interesting. We have to be aware nodal involvement is a very logical type of involvement. I mean, if you report a lymph node somewhere around the body, you should explain how it reached there. It's not random. It follows a stepwise pattern. I mean, you have the first echelon lymph nodes affected first, the second one second, the third one third, and so forth. Nodal characteristics on imaging for malignant nodes, we are looking for large nodes on CT and MRI, and for the hot nodes on FDG PET. This is a typical chain pattern of lymphonodular involvement. This is metastasis in the iliac bone. You can see the two chains that are going to the para-aortic lymph nodes, and the descending chain going to the inguinal lymph nodes. So we know where the para-aortal and inguinal lymph nodes came from. If we take a closer look at the lymphatic drainage of ovaries, there are two major pathways via proper ovarian ligament to obturatory and internal iliac, and via infundibulal pelvic ligament to the para-aortic and paracaval lymph nodes. And there is a third minor pathway which goes around the round ligament, and that's why in certain occasions we may have inguinal lymph nodes, which in this case should be considered regional lymph nodes, although in the TNM staging they are not. So when we talk about lymph nodes, we always imagine picture of artery and vein surrounded by yellow lymphatics and lymph nodes here and there. However, it's artery and vein. In this case, for example, for ovarian vessels, artery and vein reach different places. And we should look both at the inlet of artery and the inlet of vein. Here, for example, we have lymph node metastasis at the place where, I want to go back here, where the artery goes, and another one at the place where the vein goes. Actually, the one that goes to the vein was overlooked in the initial reading of the PET-CT, which may be important if we plan radiotherapy, for example. So, ovarian cancer with para-aortic lymph node metastasis, which is expected, and some strange metastasis in the perirenal space. It's a very confined space. We expect malignancy there coming from the kidney, not from somewhere else. So, how did it get there? If you take a closer look, the ovarian vein here doesn't drain to the cava vein. It goes, this is the right one, it goes to aberrant kidney vein. So we have an open access around the ovary vein to the perirenal space. And this is a simple explanation of how this lymph node get there. This is the normal vein that drains the upper part of the kidney. If you want to be aware of the lymphatic drainage, you should go through cadaveric studies, not the clinical studies. There you may find how it works. There are some crucial nodal sites in gynecological cancer that provide supradiaphragmatic breakthrough, and which actually separates N1 from M1 disease. These are around crux of the diaphragm. These are the retropleural lymph nodes, which is a switch station to supradiaphragmatic lymph nodes in three different pathways. It's a paravertebral, is a paraesophageal, which goes to subcarinal and mediastinal, and it's parallel to thoracic duct directly to left supraclavicular. Left supraclavicular is the most common supradiaphragmatic breakthrough sign, and in some of the cases is a single one. Cardiophrenic lymph nodes are very interesting because they drain the upper part of the peritoneum under the diaphragm. So when we have peritoneal spread, we expect cardiophrenic lymph nodes to appear. When we have cardiophrenic lymph nodes, we expect parasternal lymph nodes to appear. And when we have parasternal lymph nodes to appear, we expect upper mediastinal and axillary lymph nodes. So how the breakthrough takes place? On the fixed picture, we see the peritoneal carcinomatosis. The breakthrough to the cardiophrenic spread is on the second. We have parasternal, upper mediastinal lymph nodes, and lower mediastinal. This is the trace how they go there. So it's very logical. This is another example, supraclavicular breakthrough with lymph node metastasis going to two different ways, cervical and to the axilla. About the distant metastasis, if we use the formal approach, we have a cancer patient, it may have metastasis, they are unpredictable and irrespective of tumor histology. And in this case, every lung nodule is a lung metastasis. If we use a pattern recognition approach, we should know that metastatic spread is highly dependent on tumor histology and is predictable by location and by appearance. In this case, if we have a small cell cervical cancer, any lung nodule is suspicious for metastasis. If we have a serous histology, who cares? Lung nodule is a lung nodule, it's not a metastasis. Different histologies have different patterns of behavior. Spinocellular cancer has invasive local spread, very frequent nodal involvement, focal type peritoneal spread, and a very typical perineural spread. For serous carcinoma, the peritoneal spread is almost inevitable, and it's in 90% of the cases diffuse. The nodal involvement is frequent. The first distant metastatic site is pleural. Anything apart from pleural or lymph nodes is exceptionally rare for serous histologies. So be careful when your radiologist reports 5 millimeter nodule in the lung to be a metastatic one. For sarcomas, what is important, we have expansive growth pattern. Nodal involvement is rare, actually. Here we expect large masses. In the peritoneum, in the abdominal wall, we expect large masses here. So let's go side by side. Cervical cancer, the usual suspect here is squamous cell carcinoma, we talked about it. Adenocarcinomas, different types that have different imaging appearance, are the clear cell type, which have very early distant metastasis, lung, lytic bone lesions, and brain. Endometrioids, which is similar to endometrioid carcinoma. And mucinous variants, which have a very typical appearance, we'll see later on, a very typical appearance on imaging. Small cell cancer also have a specific imaging pattern and behavior pattern. It's aggressive, it gives early metastasis, they could be lung, they could be bone, but they could be bone marrow. This is specific for small cell cancers. So, just to remind for squamous cell carcinomas, perineural spread, think about it. Yeah, this is the same patient. This is small cell neuroendocrine cancer. Behavior is aggressive to even violent. I mean, these are very rude tumors. Nodal disease is common, lung disease is very common. And for bone disease, we expect bone marrow. We can expect sclerotic lesions here, which we don't expect in other types of gynecological cancer. And after that, lytic. We also expect brain. Do brain MRI for your patients with small cell cervical cancer. This is a very rare one. I have only one case. I didn't find any specific pattern in the literature, just to confirm that mesonephric cervical cancer accumulates well FDG, and FDG can be used, especially in terms of elevated tumor markers. So endometrial cancers, we know the usual suspects. Endometrioid G1, G2 behave one way, G3 behave another way. And non-endometrial histologies behave actually as badly as endometrioid G3 tumor. So for non-endometrioid histologies, we should emphasize on clear cell and on serous type endometrial cancer. High-grade serous uterine cancer behaves exactly the same like high-grade serous ovarian cancer. Very common nodal disease, diffuse peritoneal spread, pleural is commonly affected, lung and bone exceptionally rare. Liver uncommon. If somebody reports liver metastasis, think that maybe it's not a liver metastasis, but it's just peritoneal metastasis on the liver capsule. FDG avidity is high. For uterine sarcomas, another interesting entity, from imaging point of view, what we expect from these tumors, apart from aggressive behavior, is that they form large masses. Nodal disease is rare, peritoneal spread is never diffuse, it's focal and with large masses. Lung is a very common site for metastasis, liver and brain are expected. Muscle and soft tissue metastases are expected here. The difference between a low-grade and high-grade sarcomas, apart from their behavior, is the FDG avidity. Low-grade sarcomas, irrespective of whether they are stromal sarcomas or leiomyosarcomas, have low FDG avidity. Otherwise, everything is the same. So this is a low-grade sarcoma with peritoneal metastasis, with huge metastasis in the abdominal node wall, and lung metastasis. This is a high-grade sarcoma, which was operated, and it was stage P1B for this case, and it was referred for radiotherapy, I think. So we were quite surprised with the picture from a T1B sarcoma of the uterus. What's interesting here, apart from the general places for metastasis, is the myocardial metastasis. Actually, myocardium is a soft tissue, it's a muscle. So we expect myocardial metastasis from any kind of sarcomas. And at least in my practice, I have more than 20 patients with myocardial metastasis. This is the cause of death for this patient. They die either from tamponade or from rhythm disturbances. So let's go to the ovaries last. High-grade serous, low-grade serous, endometrioid, which behaves like endometrial on imaging, and rare types that have distinctive imaging features are the clear cell, mucinous, granulate cell tumor, mixed germ cell tumors, and teratomas. Once again for the serous ovarian, peritoneum, pleura, pelvic lymph nodes, low para-aortic, high para-aortic, inguinal may be seen through the round ligament pathway, mediastinal breakthrough, and parasternal breakthrough. This is put all together. Low-grade serous tumor has very distinguishable features on imaging, and especially on nuclear imaging. It's indolent, slow-growing, it's highly lymphotropic. This is a gynecological tumor with highest lymphotropism. Nodal involvement is almost always present. Peritoneal spread is micronodular rather than diffuse. Distant metastases are rare apart from pleura. Supradiaphragmatic lymph nodes are very common site of disease. What is different are the calcifications. So in low-grade tumors, low-grade serous ovarian cancer, we are looking for calcified lymph nodes, for calcifications. In any other tumor, calcium is good. For this tumor, calcium is bad, which means if you see a 3 millimeter lymph node with calcification, it's most probably metastatic. Calcifications are there because of psammoma body presence. I don't know what's the clinical significance of psammoma bodies in the histology, but it's a significant finding for us. So we always read very carefully the body of histological report to see whether there are psammoma bodies or not. If there are, we are looking for calcifications on the imaging. So huge tumor, peritoneal spread, Mary Joseph sign, umbilical metastasis in the same patient, cardiophrenic, mucinous ovarian cancer, very different to diagnose, to treat. What's specific here is the mucin production, which results in specific hypodense appearance of the lesions. Please take care of the appendix. Actually, part of the mucinous tumors of the ovary are metastases from gastrointestinal tract and mostly from the appendix, like here. This is how a mucinous tumor looks like. Very low FDG avidity when they're high because of higher prevalence of mucin, and high FDG activity when they're small. So it's a reverse size dependence. Clear cell tumors of the ovaries behave exactly like clear cell tumors of endometrium. We expect early distant metastasis. Here we expect brain. So we are not surprised to see brain metastasis in clear cell tumor. I found one case for malignant Brenner tumor. No specific pattern for this one. They are rare, rarely reported on FDG PET. What we can say is that liver metastases are most frequently reported, even more than nodal involvement in malignant Brenner tumors. And yes, they are FDG positive. This is my only case for malignant Brenner tumor. This is a very interesting one, granulate cell tumor. The specific one here is that recurrence usually takes many years. For example, the second patient, the black one, is operated at the year 2000. She has multiple resections, recurrences and resections since 2009. And you see now in the year 220, the tumor has spread to the lungs, to the liver, with a very fast growth pattern. Granulate cell tumors are FDG non-avid. They have very low FDG avidity. But if they start to be aggressive, they start to rise their FDG accumulation. So if you see a granule cell tumor which is FDG positive, expect faster clinical course. So this one was operated 2021. We were joking with Dr. Nedev that we should ask the patient to come after 5 years to see what's going on. This is also a very strange histology that I found in our records. Desmoid round cell tumor, very rare, just case reports. I cannot say anything about pattern, but yes, it's as FDG positive, so you can consider FDG in those kind of tumors. So, some practice then. A patient with cervical cancer, spinocellular, G3, operated 2012, 2014, operated again for peritoneal metastasis. 3 months later, the patient has a severe hip pain with distal irradiation. What we should do here, we should do a CT scan. The CT scan was reported to be normal. Then we did an MRI scan, which reported some minor osteodegenerative issues in the lumbar spine. We did a bone scan, which was negative. And of course, what's to do next is FDG PET. But what we expect here, no tumor masses, no bone destruction, nothing on conventional imaging. What we expect here is perineural spread, which is invisible on conventional imaging and badly read MRI. This is the patient. She also had cystectomy during her operation. So these are the stomas. Nothing so striking. Well, she has parotic lymph nodes that we expect to be there. She has a peritoneal metastasis, which is also expected. This is the CT scan, which looks almost normal. But when we hit the lights, we see these things are actually tumor infiltration, although they look like normal peripheral muscle. What to notice here is this part in the sacral channel. What you see here is that we have perineural invasion through the sacral foramina. That's why the patient has such a severe pain. So in patients with severe pain symptoms, think about perineural invasion. You don't think about it in serous carcinoma, but you should think about in spinocellular cancer. The other case, adnexial mass, omental K, biopsy from omentum, reported as adenopapillary ovarian cancer, whatever it means. Referred for staging before chemotherapy. This is a tumor. What we see here are sclerotic bone metastases. I told you we expect sclerotic bone metastases in very few gynecological cancers. Small cell cancer and sometimes endometrioid, which is not the case. So here we have also a bone marrow involvement, which doesn't consist with any type of ovarian cancer. So what we did here, this looks like metastasis from breast cancer. So what we did, we challenged the pathology to revise their reporting. They revised their reporting, and they said, okay, it could be a breast cancer. We did mammography, MRI of the breast, a small breast tumor, which was a lobular cancer, was operated, the ovary mass was operated, and it was metastasis from lobular cancer. Just because on the pattern recognition knowledge how these tumors behave, we managed to switch the case from primary ovarian, which should be treated with carboplatin and paclitaxel or something, to metastatic breast cancer, which was treated completely different. So this one is not. Lung cancer with synchronous ovary cancer. This is the same. And the final one, pattern recognition. Endometrial cancer, PT1A G1, with huge lymph nodes in the mediastinum. This is similar to what we started with. This is sarcoidosis. We just sent the patient to, for biopsy. It turned last week, I think. So it's sarcoidosis. You don't expect such a behavior in PT1A endometrial cancer. So, in conclusion, this is a very old and well-known metaphor about horses and zebras. If you see a hoof beats, you expect a horse. Not a zebra, but anyhow, in everyday practice, we know zebras exist, and we should know that. In sophisticated cases, we should take in mind that zebras and horses sometimes combine. This is a so-called zebroid, but you need a specific expertise to actually resolve this case. And in very special cases, we don't even need horses. This is a donkey zebra zebroid. So thank you for your attention.